Hello everyone, we will be starting with chapter 4 of illustrated textbook of pediatrics, developmental problems in the child with special needs. Features of developmental problems in child with special needs are developmental problems present in the perinatal period and throughout childhood with developmental delay. The difference with their peers increase as the child gets older. Cerebral palsy is the most common cause of motor impairment in children. In autism spectrum disorder, there is abnormal development of social and communication skills. Attention deficit hyperactivity disorder, that is ADHD, needs to be differentiated from normal boisterous children. Early detection of severe impairment of hearing and vision is important to minimize its detrimental effect on development. Their medical, social, emotional, and educational requirements are complex, are looked after by local multidisciplinary child development services. Any child whose development is delayed or disordered needs assessment to determine the cause and management. Neurodevelopmental problems present at all ages, with an increasing number now recognized antenatally. Table 4.1. In this table, features that may suggest neurodevelopmental concerns by age: prenatal, positive family history, for example, affected siblings or family members; ethnicity, for example, Tay-Sachs disease in Jewish parents; antenatal screening tests, for example, ultrasound including nuchal thickness, triple blood test, or non-invasive prenatal testing, that is NIPT; cell-free DNA testing of fetal cells for maternal blood for conditions such as Down syndrome; neural tube defects, for example, spina bifida and hydrocephalus; amniocentesis for suspected genetic disorders. Now, perinatal, following birth asphyxia and or a neonatal encephalopathy; preterm infants with intraventricular hemorrhage; periventricular leukomalacia; post-hemorrhagic hydrocephalus; dysmorphic and neurocutaneous features; abnormal neurological behavior, tone, feeding, movements, seizures; visual inattention. In infancy, global developmental delay, delayed or asymmetrical motor development; neurocutaneous and dysmorphic features, cataracts; vision or hearing concerns by parents or after screening; preschool speech and language delay, abnormal gait, clumsy motor skills, poor social communication skills; behavior, stereotypical overactivity or inattention; school age problems with balance and coordination, learning difficulties, attention control, hyperactivity; specific learning difficulties, for example, dyslexia and dyspraxia; social communication difficulties, or any age acquired brain injury, for example, after meningitis or head injury; and loss of skills. Many are identified in the neonatal period because of abnormal neurology or dysmorphic features. During infancy and early childhood, problems often present at an age with a specific area of development is most rapid and prominent, i.e. motor problems during the first 18 months of age, speech and language problems between 18 months and 3 years, and social and communication disorders between 2 to 4 years of age. Abnormal development may be caused not only by neurodevelopmental disorders that are given in table 4.2, but also by ill health or if the child's physical or psychological needs are not met. When carrying out a clinical examination on a young child with a possible developmental problem, ask the parent what the child's abilities are. Start at a level below what a child of that age is likely to be able to do to retain confidence of the parent and child. Observe the child for the first moment. Make it fun. The assessment should be perceived as a game by the child. Toys to use are cubes, a ball, car, doll, pencil, paper, pegboard, miniature toys, picture book. Adapt their use to the child. Formulate a developmental picture in terms of gross motor, vision, and fine motor, hearing, speech and language, and social, emotional, and behavior. As you become more confident, you will screen all these skills simultaneously. Assess the child to a short level above what they appear able to do in order to establish their ceiling of skill for each developmental area. Remember to adjust developmental expectations for prematurity. At the end of developmental screening, you should be able to describe what a child is able to do and when the child cannot do. If the abilities are within normal limits for age, and if not, which developmental fields are outside the normal range. Clinical signs to look for that may aid diagnosis or guide investigations are patterns of growth, height, weight, head circumference with central plotting, dysmorphic features, face, limb, body proportions, cardiac and genitalia, skin, neurocutaneous stigmata, injuries, cleanliness, central nervous system examination, abdominal posture, symmetry, wasting, tone and power, deep tendon reflexes, clonus, plantar responses, cranial nerves, cardiovascular examination. Abnormalities are associated with many dysmorphic syndromes. Visual function and ocular abnormalities, hearing by questioning parents about hearing and language development and checking if neonatal hearing screenings was done. Patterns of mobility, dexterity, hand dominance, communication and social skills, general behavior, and cognition. Many examination findings can be predicted from observation of functional skills and behavior. Many parental concerns about their child's development are found to be variations of normal, in which case the parent should be reassured. If in doubt, observe the child's progress over a period of time. Now the table 4.2, conditions that cause abnormal development and learning difficulties. Prenatal, genetic, chromosome, DNA disorder, for example, Down syndrome, Fragile X syndrome, chromosomal microdeletion or duplication, cerebral dysgenesis, for example, microcephaly, absent corpus callosum, hydrocephalus, neuronal migration disorder, cerebrovascular, stroke, hemorrhagic or ischemic, metabolic, hypothyroidism, phenylketonuria, teratogenic, alcohol and drug abuse, congenital infection, rubella, cytomegalovirus, toxoplasmosis, and HIV, neurocutaneous syndrome, tuberous sclerosis, neurofibromatosis, Sturge-Weber, and ITO syndrome. Perinatal, extreme prematurity, intraventricular hemorrhage, periventricular leukomalacia. Birth asphyxia, hypoxic ischemic encephalopathy. Metabolic, symptomatic hypoglycemia, hyperbilirubinemia. Postnatal, infection, meningitis, encephalitis, anoxia, suffocation, near drowning, seizures, trauma, head injury, accidental or non-accidental, metabolic, hypoglycemia, inborn error of metabolism, cerebrovascular, stroke, nutritional deficiency, maternal deficiency, breastfed, food intolerances, and restrictions. Other include unknown, about 25%, chronic illness, physical abuse, and emotional neglect. Note, the site and severity of brain damage influence the clinical outcome, i.e., whether specific or global developmental delay, learning, or physical disability. Abnormal development key concepts. The terminology can be confusing, but delay implies slow acquisition of all skills, global delay, or of one particular field or area of skill, specific delay, particularly in relation to developmental problems in the 0 to 5 year age group. Learning difficulty used in relation to children of school age and may be cognitive, physical, both, or relate to specific functional skills. Disorder, maldevelopment of a skill. The following are agreed definitions. Impairment, loss of abnormality of physiological function or anatomical structure. Disability, any restriction or lack of ability due to the impairment. Disadvantage, that results from the disability and limits or prevents fulfillment of a normal role. It is situationally specific. A child with a learning disability may, for example, be a good skier or enjoy swimming. The term handicap is now discouraged as it can imply a person deserves pity. Difficulty and disability are often used interchangeably, but difficulty is particularly in an educational context. Impairment is now generally used instead of disability when describing problems such as visual impairment or hearing impairment. The pattern of abnormal development, global or specific delay, can be characterized as shown in the figure: slow but steady, plateau effect, showing regression, acute regression following acute brain injury with subsequent slow recovery but not to normal levels, that is partial recovery, or slow regression as with neurodegenerative disorders. The severity can be categorized as mild, moderate, severe, profound. Other features of developmental delay are the gap between normal and abnormal development becomes greater with increasing age and therefore becomes more apparent over time, as given in the figure. It may be the presentation of a wide variety of underlying conditions, as given in table 4.2. The site and severity of brain damage influences the clinical outcome, whether there will be specific or global developmental delay, learning or physical disability. It may be genetic with important implication to the family. There's a wide age band across which it can be normal to achieve a developmental skill. Limit ages denote beyond the normal range. The choice of investigation to identify the cause is influenced by the child's age, the history, and clinical findings that will be given in the table next. In some children, no cause can be identified even after extensive investigation. Now, the summary: disordered development incorporates global and specific delay to disorder, learning difficulty, impairment, and disability. Varies in pattern of progression and severity, becomes more apparent with age. Now, developmental delay. Global developmental delay, also called early developmental impairment, implies delay in acquisition of all skill fields. Those are gross motor, vision and fine motor, hearing and speech, language and cognition, social, emotional, and behavior. It usually becomes apparent in the first 2 years of life. Global developmental delay is likely to be associated with cognitive difficulties, although these may only become apparent several years later. The presence of global developmental delay should always generate investigation into a possible cause, such as those listed in this table, which we'll discuss later. When children become older and the clinical picture is clearer, it is most appropriate to describe the individual difficulties such as learning disability, motor disorder, and communication difficulty rather than using the term global developmental delay. Specific developmental impairment is when one field of development or skill area is more delayed than other. It may also be developing in a disordered way. Global developmental delay usually presents in the first 2 years of life. Now, in the table, investigations or assessment to consider for developmental delay: cytogenetic, comparative genomic hybridization, microarray, a chromosome karyotype, fragile X analysis, DNA fluorescence, in situ hybridization analysis, for example, for chromosomes 7, 15, 22 deletions, telomere screening, whole exome sequencing, metabolic, thyroid function tests, liver function tests, bone chemistry, urea and electrolytes, plasma amino acids, blood film, creatine kinase, blood lactate, very long chain fatty acids, ammonia, blood gases, white cell, lysosomal enzyme, urine amino and organic acids, urine mucopolysaccharides, also known as GAG, and oligosaccharide screen, urine reducing substances, lead levels, urate, ferritin, biotinidase, vitamin B6, B12, maternal amino acids for raised phenylalanine infection, congenital infection screen for cytomegalovirus, etc. Imaging, which can include cranial ultrasound in newborn, CT and MRI brain scans, skeletal survey, bone age, neurophysiology, which will include EEG for seizures and can be diagnostic for specific neurological disorders and syndromes. Nerve conduction studies, electromyogram, visual evoked potentials, electroretinogram, histopath and histochemistry, nerve, skin, and muscle biopsy. Other include hearing, vision, clinical genetics, cognitive and behavioral assessment, clinical and educational psychologist, and therapy assessment, physiotherapy, occupational therapy, speech and language therapy, child psychiatry, dietitian, nursery, school reports. Now, abnormal motor development. This may present as a delay in acquisition of motor skills, for example, head control, rolling, sitting, standing, walking, or as problems with balance and abnormal gait, asymmetry of hand use, involuntary movements, or rarely loss of motor skills. Concern about motor development usually presents between 3 months to 2 years of age, when acquisition of motor skills is occurring most rapidly. Examination may reveal underlying abnormal motor signs. Causes of abnormal motor development includes central motor deficit, for example, cerebral palsy, congenital myopathy, primary muscle disease, spinal cord lesions, for example, spina bifida, global developmental delay, as in many syndromes, or of unidentified cause, as hand dominance is not acquired until 1 to 2 years of age or later. Asymmetry of motor skills during the first year of life is always abnormal and may suggest an underlying hemiplegia. Late walking, more than 18 months of old, may be caused by any of the aforementioned causes, but also needs to be differentiated from children who display the normal locomotor variants of bottom shuffling and commando crawling, as we have mentioned in the previous chapter, where walking occurs later than with crawlers, and from children with joint hypermobility who may also achieve walking later than average. Concerns about abnormal motor development needs assessment by a neurodevelopmental pediatrician and physiotherapist. Ongoing physiotherapy input and subsequent involvement of an occupational therapist are also likely to be needed. Now, cerebral palsy. CP is difficult to define, but the International Group for Surveillance of Cerebral Palsy in Europe defines it as an umbrella term for a permanent disorder of movement and or posture and of motor function due to a non-progressive abnormality in the developing brain. The motor disorders of CP are often accompanied by disturbances of cognition, communication, vision, perception, sensation, behavior, seizure disorder, and secondary musculoskeletal problems. Although The causative lesion is non-progressive and damage to the brain is static. Clinical manifestation emerge over time. Clinical manifestations emerge over time, reflecting the balance between normal and abnormal cerebral maturation. Motor dysfunction is usually evident early, often from birth. If the brain injury occurs after the age of 2 years, it is diagnosed as acquired brain injury. CP is the most common cause of motor impairment in children, affecting about 2 per thousand live births. Causes are about 80% of CP is antenatal in origin due to cerebrovascular hemorrhage or ischemia, cortical migration disorder, or structural maldevelopment of the brain during gestation. Some of these problems are linked to gene deletion. Other antenatal causes are genetic syndromes and congenital infections. Only about 10% of cases are thought to be due to hypoxic ischemic injury before or during delivery, and this proportion has remained relatively constant over the last decade. About 10% are postnatal in origin. Preterm infants are especially vulnerable to brain damage from periventricular leukomalacia, secondary to ischemia and or severe intraventricular hemorrhage and venous infarction. The improved survival of extremely preterm infants have been accompanied by an increase in survivors of with CP, although the number of such children is relatively small. Postnatal causes are meningitis, encephalitis, encephalopathy, head trauma from accidental or non-accidental injuries, symptomatic hypoglycemia, hydrocephalus, and hyperbilirubinemia. MRI brain scans may assist in identifying the cause of CP, in directing further investigation and in supporting explanations to the parents, but it is not required to make the diagnosis. Clinical presentation: many children who develop CP will have been identified as being at risk in the neonatal period. Early features of CP are abnormal limb and or trunk posture and tone in infancy with delayed motor milestones that are explained in the figure shown. This may be accompanied by slowing of head growth, feeding difficulties with oromotor accommodation, slow feeding, gagging and vomiting, abnormal gait once walking is achieved, asymmetric hand function before 12 months of age. In CP, primitive reflexes which facilitate the emergence of normal patterns of movement and which need to disappear for motor development to progress may persist and become obligatory. The diagnosis is made by clinical examination with particular attention to assessment of posture and the pattern of tone in the limbs and trunk, hand function and gait. CP is now categorized according to neurological features as spastic, bilateral, unilateral, not otherwise specified, almost 90%. Dyskinetic is 6%, ataxic is 4%, and other. The gross motor function level functional ability is described using the gross motor function classification system, which is shown in this table, GMFCS. These are the levels. Level 1 is walked without limitation. Level 2 is walks with limitations. Level 3 is walks using a handheld mobility device. Level 4 is self mobility with limitations, may use powered mobility. Level 4 is transported in a manual wheelchair. In the past, the description was based on the parts of the body affected, that is hemiplegia, quadriplegia, diplegia, for children with high risk factors for brain damage such as significant prematurity or those with difficulties around the time of birth. A formal standardized assessment of journal movements may identify at a very young age those at greater risk of developing CP. It is specialized assessment usually performed by a trained therapist or clinician. Spastic cerebral palsy: in this type, there's a damage in the upper motor neuron, pyramidal or corticospinal tract pathway. Limb tone is persistently increased. spasticity with associated brisk, deep tender reflexes and extensive transfer responses. The tone in spasticity is velocity dependent, so the faster the muscle is stretched, the greater the resistance it will have. This elicits a dynamic catch, which is the hallmark of spasticity. The increased limb tone may suddenly yield under pressure in a clasp knife fashion. Limb involvement is increasingly described as unilateral or bilateral to acknowledge asymmetrical signs. Spasticity tends to present early and may even be seen in the neonatal period. Sometimes there is initial hypotonia, particularly of the head and trunk. These are three main types of spastic CP. Number one is unilateral hemiplegia, unilateral involvement of the arm and the leg. The arm is loosely affected more than the leg, with the face paired. Affected children often present at 4 to 12 months of age with fisting of the affected hand, a flexed arm, and a pronated forearm, asymmetric reaching, hand function, or toe pointing when lifting the child. Subsequently, a tiptoe walk, a toe heel gait, or the affected side may become evident. Affected limbs may initially be flaccid and hypotonic, but increased tone soon emerges as a predominant sign. The medical history may be normal with an unremarkable birth history and no evidence of hypoxic ischemic encephalopathy, giving rise to the possibility of a prenatal cause which is often silent. In some children, the condition is caused by neonatal stroke. Most severe vascular insults may cause a hemianopia, loss of half of visual field of the same side of the affected limbs. The second one is bilateral quadriplegia. All four limbs are affected, often severely. The trunk is involved with a tendency to opisthotonus, extensive posturing, poor head control, and low central tone. Just shown in the figure later. This more severe form of CP is often associated with seizures, microcephaly, and moderate or severe intellectual impairment. These may have been a history of perinatal hypoxic ischemic encephalopathy. Third one is bilateral diplegic. All four limbs with the legs are affected to a much greater degree in the arms, so that hand function may appear to be relatively normal. Motor difficulties in the arms are most apparent with the functional use of the hands. Walking is abnormal. Diplegic is one of the patterns associated with preterm birth due to periventricular brain damage. MRI brain scan may show periventricular leukomalacia. Dyskinetic cerebral palsy. Dyskinesia refers to movements that are involuntary, uncontrolled, occasionally stereotyped, and are often more evident with active movement or stress. Muscle tone is variable and primitive motor reflex pattern predominate. May be described as these three patterns: chorea, athetosis, and dystonia. Chorea is irregular, sudden, and brief non-repetitive movements. Athetosis is slow rhythmic movements occurring more distally, such as fanning of the fingers. Dystonia, simultaneous contraction of agonist and antagonist muscles of the trunk and proximal muscles, often giving a twisting appearance. Intellect may be relatively unimpaired. Affected children often present with floppiness, poor trunk control, and delayed motor development in infancy. Abnormal movements may only appear towards the end of the first year of life. The signs are due to damage or dysfunction in the basal ganglia or their associated pathways that are extrapyramidal. In the past, the most common cause were hyperbilirubinemia, kernicterus due to rhesus disease of newborn, but it is now hypoxic ischemic encephalopathy at term. MRI brain scan will often show bilateral changes predominantly in the basal ganglia. The last one is ataxic hypotonic cerebral palsy. Most are genetically determined when due to acquired brain injury, cerebellum, or its connections. The signs occur on the same side as the lesion but are usually relatively symmetrical. There is early truncal limb hypotonia, poor balance, and delayed motor development. Incoordinate movements, intention tremor, and an ataxic gait may be evident later. Different types of CP child are summarized in the next figure will be shown later. Management. Parents should be given details of the diagnosis as early as possible, but prognosis is difficult during infancy until the severity and pattern of evolving signs and the child's developmental progress have become clearer over several months or years of life. Children with CP are likely to have a wide range of associated medical, psychological, and social problems, making it essential to adopt a multidisciplinary approach to assessment and management, as described later. There are recently developed novel treatments for treating hypotonia and CP, such as botulinum toxin, injections to muscles, selective dorsal rhizotomies. A proportion of the nerve roots in the spinal cord are selectively cut to reduce spasticity, intrathecal baclofen, a skeletal muscle relaxant, and deep brain stimulation of the basal ganglia. Now, the picture shown normal and abnormal motor development, normal and abnormal motor development from medium to limit ages, shown 1.5 to 3 months. Normal motor development, child is pushes up to arms, holds head up. The abnormal motor development, unable to lift head or push up on arms, stiff extended legs, pushing back with head, constantly fisted hand, and stiff leg on one side, difficulty moving out of this position. Months from 3 to 6 months, normal motor development, sits with support, holds held up, round back. Abnormal motor development will show unable to lift head, floppy trunk, stiff arms, extendable legs, arms flexed and held back, stiff cross legs. 6 to 9 months. In normal motor development, child sits without support, arms free to reach and grasp. And in abnormal motor development, child will show rounded back, poor use of arms for play, stiff legs, pointed toes, poor head control, difficulty getting arms forward, arches back, stiff legs, poor ability to lift head and back, will not take weight on legs. From 9 to 13 months, the child pulls to stand. In abnormal motor development, not interested in weight bearing, difficulty in pulling to stand, stiff legs, pointed toes, cannot crawl or on hands and knees, may use only one side of body to move. From ages from 12 to 18 months, the normal motor development shows independent standing or walking. In abnormal development, whole arm or both arms stiffly and bent, excessive tiptoe gait, sits with weight to one side, uses predominantly one hand for play, one leg may be stiff. In the next picture, it is shown an infant with spastic bilateral quadriplegic cerebral palsy, showing scissoring of the legs from excessive adduction of the hips, pronated forearms, and fisted hands. Now the summary box. The cerebral palsy has many causes. Only about 10% follow hypoxic ischemic encephalopathy. Usually presents in infancy with abnormal tone and posture, delayed motor milestones, and feeding difficulties. May be spastic, dyskinetic, ataxic, or a mixed pattern. Now the summary shows pattern of cerebral palsy, and this is a type of cerebral palsy with etiology and clinical features. The first one shows unilateral cerebral palsy, hemiplegic, spastic, or dystonic. Etiology is often due to perinatal middle cerebral artery infarct. Clinical features show spastic or dystonic tone, one side of body affected, opposite to the side of the brain lesion, arm often most affected than leg, may have visual field effects on side of hemiplegia, risk of learning difficulties and seizures, often GMFCS level 1 and level 2, which is walks with limitations, and level 1 is walks without limitations, and level 2 is walk with limitations. The second one is bilateral spastic cerebral palsy, diplegic, damage to the periventricular areas of developing brain, often associated with prematurity. Leg motor fibers from the homunculus are closest to the ventricles, so legs more affected than arms. Clinical features: young child, pattern with walking on their toes and seizing of the legs. Older child, crouch gait pattern is typical when the child gets heavier and can't remain on the toes. Predominantly affect legs, arms may be subtly affected, supination, fine motor control. Spasticity is the main motor type, usually no feeding, communication difficulties, and good cognition, often associated with uh, squints. Frequently, GMFCS is level is 1, 2, 3. 1 is walking which walks without limitations. Level 2 is walks with limitations, and level 3 is walks using a handheld mobility device. Now the third one is bilateral spastic cerebral palsy, quadriplegia, four-limb pattern. That etiology has extensive damage to the periventricular areas of developing brain, including cortex. Clinical features include both arm and leg involvement, predominantly spastic with dystonia often also present. Associated with learning difficulties, feeding difficulties, problems with speech, vision and hearing, seizures, common and increased risk of hip subluxation and dislocation, and scoliosis. Usually dependent on others for activities of daily living. Powered mobility is a common requirement. Often GMFCS is levels is 4 and 5. Level 4 is of a GMFCS, which is gross motor function classification system, is self mobility with limitations, may use powered mobility. Level 5 is transported in a manual wheelchair. Now the last one is a dyskinetic cerebral palsy, dystonia, athetosis, chorea. Etiology is perinatal asphyxia, particularly affecting the basal ganglia. Also kernicterus, but this is now rare. Typical dystonic pattern with open mouth posture and internal rotation and extension of the arm. Mixture of motor patterns including dystonia, athetosis, and chorea. Cognition may be preserved, but feeding difficulties are common. Risk of hip deformity and scoliosis. Many are dependent on others for activities of daily living due to their severe movement difficulties, even if cognitively normal. Usually GMFCS level 4 to 5, which is self mobility with limitations, may use powered mobility. Level 5 is transported in a manual wheelchair. Now we will talk about disordered speech and language development. A child may have a deficit in either receptive or expressive speech and language, or both. The deficit may be a delay or a disorder. Speech and language delay may be due to hearing loss, global developmental delay, difficulty in speech production from an anatomical deficit, for example, cleft palate, or oromotor incoordination, for example, CP. Environmental deprivation, lack of opportunity for social interaction, normal variant, familial pattern. Speech and language disorders include disorders of language comprehension, language expression, inability or difficulty in producing speech whilst knowing what is needing to be said, intelligibility, and speech production, such as stammering, disfluency, dysarthria, or verbal dyspraxia. Pragmatics, difference between sentence meaning and speaker's meaning. construction of sentences, semantics, grammar, social communication skills. Autistic spectrum disorder, speech and language problems are usually first suspected by parents or primary healthcare professionals. A hearing test and assessment by speech and language therapists are the initial steps. In early years, there is considerable overlap between language and cognitive intellectual development. Involvement of a neurodevelopmental pediatrician and pediatric audiological physician is indicated. Speech and language therapy may be provided on a continuous burst or review basis. The speech therapist may promote alternative methods of communication such as signing. Special schooling, usually language units attached to a mainstream primary school, is available but only appropriate for a very few. Many children with early speech and language problems will need learning support at school entry. There are many tests of language development. These include the symbolic toy test, which assesses very early language development, the Renal test for receptive and expressive language used for preschool children. Abnormal development of social communication skills known as autism spectrum disorder. Children who fail to acquire normal social and communication skills may have an autism spectrum disorder. The prevalence of autism spectrum disorder is 3 to 6 per thousand live births. The worldwide prevalence is estimated to be 7.6 per thousand persons. It is most common in boys. Presentation is usually between 2 to 4 years of age, when language and social skills normally rapidly expand. The child presents with a triad of difficulty and associated comorbidities, which are shown in the box, which we will discuss later. Where only some of the behaviors are present, the child may be described as having autistic features but not the full spectrums. Asperger's syndrome refers to a child with social impairment of an autism spectrum disorder but at a milder end and near normal speech development. Such children still have major difficulties with the give and take of ordinary social encounters, a stilted way of speaking, and narrow, unusual, and often intense interest which they do not share with others, and are often clumsy. In reality, autism spectrum disorders are a continuum of behavioral traits ranging from severe form of autism with or without severe learning difficulties to the milder Asperger's syndrome or to autistic features occurring secondary to other clinical problems. Autism spectrum disorders are diagnosed by assessing for specific features and seeing if they meet a specific threshold according to the Diagnostic and Statistical Manual in the US, that is DSM-5, or International Classification of Diseases for DSM-5 diagnosis. Terminology such as Asperger's syndrome and autistic disorder are no longer used, and these are replaced by the term autism spectrum disorder with a description of the particular strengths and difficulties of the child. Autism is diagnosed by observation of behavior, including the use of formal standardized tests, autism diagnostic interview, autism diagnostic observation schedule, and diagnostic interview for social and communication disorders. It may arise as a result of different organic processes, but in many cases, no specific cause can be identified. There is probably multiple etiology with a genetic component in at least some children. The condition is not the result of emotional trauma or deviant parenting. There is no evidence of a suggested link with the measles, mumps, and rubella vaccine. The management includes the condition has lifelong consequences of varying degree for the child's social, communication, and learning skills. Parents need a great deal of support. They often feel initial guilt that they did not recognize the problem early. A wide range of interventions have been promoted over the last 10 years, but with little evidence except for applied behavioral analysis. A behavior modification approach that helps to reduce ritualistic behavior, develop language, social skills, play, and to generalize use of all these skills. It is currently the most widely accepted treatment approach, but requires 25 to 30 years of individual therapy each week, so it's costly and time consuming, and appropriate educational placement needs to be sought. Some schools incorporate an applied behavioral analysis approach into the teaching methods. Fewer than 10% of children with autism are able to function independently as adults. Autism spectrum disorder presents at 2 to 4 years of age with impaired social interaction, speech and language disorder and imposition of routines with ritualistic and repetitive behavior, usually managed by behavior modifications such as applied behavioral analysis. Now the box shown, which shows features of autism spectrum disorder: impaired social interaction, does not seek comfort, share pleasure, form close friendship, prefers own company, no interest or ability in interacting with peers, play or emotions, gaze avoidance, lack of joint attention, socially and emotionally inappropriate behavior, does not appreciate that others have thoughts and feelings, lack of appreciation of social cues. Speech and language disorder may include delayed development, maybe swear, limited use of gesture and facial expressions, formal, pedantic language, monotonous voice, impaired comprehension with over literal interpretation of speech, echoes questions, repeat instructions, refers to self as you, can has superficially good expressive speech, imposition of routines with ritualistic and repetitive behavior on self and others, with violent temper tantrums if disrupted, unusual stereotypical movements such as hand flapping and tiptoe gait, concrete play, poverty of imagination in play and journal activities, peculiar interest and repetitive adherence, restriction in behavior repertoire. Comorbidities include journal learning and attention difficulties about 2/3, seizures about 1/4, often not until adolescence, affective disorders, anxiety, sleep disturbances, mental health disorders, attention deficit hyperactivity disorder, which is ADHD. A slow acquisition of cognitive skills, journal learning difficulty. The term learning difficulty or disability reflecting cognitive learning difficulties is now preferred to mental retardation or mental handicap. Medical and educational classification of IQs, which is intelligent quotient, can be different, with medical models having lower ranges. The education levels briefed in the following sections are useful for journal use. Children with borderline and mild IQ 70 to 80 learning difficulties are usually supported by additional helpers, learning support assistants in mainstream schools, whereas children with moderate IQs 50 to 70, severe IQ 35 to 50, and profound IQ less than 35 learning difficulties are likely to need the resources of special schools. Severe profound learning difficulties are usually apparent from infancy as marked global developmental delay, whereas moderate learning difficulties emerge only as delay in speech and language becomes apparent. Mild learning difficulties may only become apparent when the child starts school or much later. A child with profound learning difficulties will have no significant language and be completely dependent for all of his or her needs. A child with severe learning difficulties is likely to be able to learn minimal self-care skills and acquire simple speech and language. Both will need high or total supervision and support throughout life. The prevalence of severe learning difficulties is about 3 to 4 per 1,000 children. Most have an organic cause irrespective of social class, in contrast to moderate learning difficulty 30 per 1,000 children, in which children of parents from lower socioeconomic classes are overrepresented. Common causes of developmental delay and learning difficulty are listed in the table above. Specific learning difficulties implies that the skill described is more delayed than would be expected for the child's level of cognitive ability. Some examples are described below. Developmental coordination disorder, dyspraxia. Developmental dyspraxia is a disorder of motor planning and or execution with no significant findings on standard neurological examination. It is a disorder of the higher cortical processes, and there may be associated problems of perception, how the child interprets what he or she sees and hears, use of language, and putting thoughts together. The difficulty may impact on educational progress and self-esteem and suggest the child has greater academic difficulties that then may be the case. Features include problems with handwriting, which is typically awkward, messy, slow, irregular, and poorly spaced, dressing button laces clothes, cutting up food, poorly established laterality, copying and drawing, messy eating from difficulty in coordinating Biting, chewing, and swallowing, oromotor dyspraxia, dribbling of saliva is common. Assessment and advice are primarily from an occupational therapist and, when necessary, speech and language therapist, oromotor skills and speech. A visual assessment may also be helpful. Dyspraxia, in its milder form, often goes undetected during the first few years of life as the child achieves gross motor milestones at the normal times. With therapy, emphasis on sensory integration, sequencing, executive planning, and where needed, speech language therapy. And maturity. The condition should improve. Verbal dyspraxia is where there are more specific difficulty relating to speech production in the absence of muscle or nerve damage. It is considered part of developmental dyspraxia. Dyslexia is a disorder of reading skills disproportionate to the child's IQ. The term is often used when the child's reading age is more than 2 years behind his or her chronological age. Assessment needs to include vision and hearing and involves an educational psychologist. Dyscalculia, dysgraphia, these are disorders in development of calculation on writing skills. Disorders of executive function. The executive functions are a collection of cognitive processes that are responsible for activities such as planning and organization, self-regulation, cognitive flexibility, problem solving, and abstract reasoning. They are very necessary to function and interact within one social environment. Deficits in executive function can occur as a consequence of acquired brain injury, such as those following hypoxia, infection, stroke, or trauma. Executive dysfunction may manifest as poor concentration, forgetfulness, volatile mood, overeating, and poor social skills. Associated comorbidities of specific learning disorders. These are attention deficit disorders, hyperactivity, sensory processing disorder, poor sensory integration, skills of touch and balance, depression, conduct disorders, obsessive compulsive disorder. Management of specific learning disorders. Assessment may include vision and hearing and assessment by an occupational therapist, physiotherapist, speech and language therapist, and educational psychologist. Comorbidities need to be identified. Treatment is aimed at improving skill acquisition with educational and information technology support as appropriate. Problem with concentration and attention deficit hyperactivity disorder, that is ADHD. Young children are characteristically lively, some more than others by virtue of their immaturity. When their level of motor activity exceeds that regarded as normal, they may be termed as hyperactive by their parents. This is a judgment that depends upon the parents' standards and expectations. The term can thus incorrectly be used as a complaint about a child which is normally active in overall terms but who can be cheeky and boisterous at times. Such a child is not hyperactive, but the parents need advice about how to handle unwanted behavior. In the true hyperconnected disorder or attention deficit hyperactivity disorder, ADHD, the child is undoubtedly overactive in most situations and has impaired concentration with a short attention span or distractibility. Differences in diagnostic criteria and threshold mean that prevalence rates among prepubertal school children are variously estimated as 10 to 50 per thousand children, with boys exceeding girls threefold. There is a powerful genetic predisposition, and the underlying problem is a dysfunction of brain neuron circuits that rely on dopamine as a neurotransmitter and which controls self-monitoring and self-regulation. Affected children are unable to sustain attention or persist with tasks. They cannot control their impulses. They manifest disorganized, poorly regulated, and excessively active. Excessive activity, have difficulty with taking turns and sharing, are socially disinhibited and butt into other people's conversations and play. Their inattention and hyperactivity are worst in familiar or uninteresting situations. They also cannot regulate their activity according to the situation. They are fidgety, have excessive movements inappropriate to task completion, lose possessions, and generally disorganized. Typically, they have short tempers and form poor relationship with other children who find them exasperating. The children do poorly in school and lose self-esteem. They may drift into antisocial activities for a variety of reasons, partly because the behavior drives parents, teachers, and peers to use coercion and punishment which are ineffectual or breed resentment. In addition to child psychiatric or pediatric evaluation, the child will usually need to be assessed by an educational psychologist. First line management in preschool and school age children with mild to moderately severe disorder is the active promotion of behavioral and educational progress by offering specific advice to parents and teachers to build concentration skills, encourage quiet self occupation, increase self esteem, and how to moderate extreme behavior. Behavioral interventions similar to those embedded in parenting programs are helpful. These involve having clear rules and expectations and consistent use of rewards to encourage adherence and, where appropriate, consequences to discourage unacceptable behavior. For those children in whom this is insufficient, hyperactivity responds symptomatically to several types of medication. Although this is usually reserved for children older than 6 years of age, stimulants such as methylphenidate or dexamphetamine, and non-stimulants such as atomoxetine reduces excessive motor activity and improves attention on task and focused behavior. The usual approach is not to put the child on medication until behavioral and education progress is actively promoted by the specific measures mentioned earlier. However, in severe cases with high degrees of impairment, simultaneous psychosocial and medical treatment may be required. It may be necessary to continue medication for several years, sometimes into adulthood. Yearly off medication trial is recommended to evaluate the need for continuing treatment. Specialist supervision is mandatory. Close liaison with the school is required throughout the years of treatment. The role of diet in the cause and management of hyperactivity is controversial. Current evidence indicates that the sort of diet which aims blindly to reduce sugar, artificial additives, or colorants has no effect. Few children display an idiosyncratic behavioral reaction such as excitability or irritability to particular food. If this seems likely, trying the child on an exclusion of that particular food may be useful. In general, food and drinks with caffeine are not advised. Overzealous dietary exclusion can lead to malnutrition, especially in a child or stimulant medication on a stimulant medication that may already have the side effect of appetite reduction. Now, a little bit of summary about ADHD. Affects male more than females. Clinical features include contains sustained attention, cannot sustain attention, excessively active, socially disinhibited, easily distracted and impulsive, poor at relationships, prone to temper tantrums, poor school performance management, educational psychologist assessment, behavioral programs in school, parenting intervention, medication if necessary. Next is hearing impairment. Any concern about hearing impairment should be taken seriously. Any child with delayed language or speech, learning difficulties, or behavioral problems should have his or her hearing tested, as a mild hearing loss may be the underlying cause without parents or other carers realizing. Unilateral hearing loss can cause hearing difficulties when the good ear has an acute ear infection or glue ear. It can also cause difficulty with localizing sounds. Hearing loss may be sensorineural, caused by a lesion in the cochlea or auditory nerve, and is usually present at birth, conductive from abnormalities of the ear canal or the middle ear, most often from otitis media with effusion. The causes, natural history and management of hair loss are listed in table 4.5. Hearing tests are described in previous chapter. The typical audiogram and sensorineural conductive hearing loss is shown in the figure. Sensorineural hearing loss. The type of hearing loss is as uncommon. In England, the incidence of permanent childhood hearing impairment PCHI is 0.9 per 1000 live births, when unilateral PCHI adding a further 0.7 per 1000 live births and another 0.7 per 1000 children acquire permanent hearing loss by the age of 10 years. It is usually present at birth and or develops in the first few months of life. It is irreversible and can be of any severity, including profound The child with severe bilateral sensorineural hearing impairment will need early amplification with hearing aids for optimal speech and language development. Hearing aid use requires close supervision beginning in the home together with the parents and continuing into school. Children often resist wearing hearing aids because background noise can be amplified unpleasantly. Children with microtia, congenital underdevelopment, external ear, and meatal atresia can be helped with bone conduction hearing aids. Cochlear implants may be required where hearing aids give insufficient amplification. As shown in the figure, many children with moderate hearing impairment can be educated within the mainstream school system or in partial hearing units attached to mainstream schools. Children with hearing impairment should be placed in the front of the classroom so that they can readily see the teacher. Gestures, visual context, and lip movement will also allow children to develop language concepts. Speech may be delayed, but with appropriate therapy can be of good quality. Modified and simplified signing such as Mrcpch can be helpful for children who are both hearing impaired and learning disabled. Specialist teaching and support service in preschool and school years is provided by Pediatric teachers for children with hearing impairment. Those with profound hearing impairment may need to attend a school for, for children who are deaf. Conductive hearing loss from middle ear disease is usually mild or moderate but may be severe. It is much more common than sensorineural hearing loss in association with upper respiratory tract infections. Many children have episodes of hearing loss which are usually self-limiting. In most cases of chronic otitis media with infusion, the hearing loss may last many months or years. In most affected children, there are no identifiable risk factors present, but children with Down syndrome, cleft palate, and atopy are particularly prone to hearing loss from middle ear disease. Impedance audiometry tests, which measure the air pressure within the middle ear and the compliance of the tympanic membrane, determine if the middle ear is functioning normally. If the condition does not improve spontaneously, medical treatment, decongestants, or a long course of antibiotics or treatment of nasal allergy can be given. If that fails, surgery is considered with insertion of tympanostomy tubes, grommets, with or without the removal of adenoids. Hearing aids are used in case where problems recur after surgery. The decision whether to intervene surgically should be based on the degree of functional disability rather than on absolute hearing loss. Any child with poor or delayed speech or language must have his or her hearing assessed. Both figures are shown audiogram showing normal hearing and loudness of normal speech with blue area. Consonants are high frequency sounds, whereas vowels are low frequency sounds. There's another audiogram showing bilateral conduction hearing loss. There is a 30 decibel to 40 decibel hearing loss in both the right and left ears. Audiogram showing bilateral profound sensorineural hearing loss, and audiogram showing bilateral high frequency sensorineural hearing loss. The figure 4.7 cochlear implant, there is a microphone to detect sound and a speech processor and a transmitter and receiver stimulator. They convert speech into electrical impulses which are conveyed to the auditory nerve bypassing the ear. It provides a deaf person with a representation of sounds. Now the table showing causes and management of hearing loss, causes of sensorineural and conductive hearing loss. Sensorineural contains genetic, the majority, antenatal and perinatal, congenital infection, preterm, hypoxemia, encephalopathy, hyperbilirubinemia, postnatal meningitis, encephalitis, head injury, drugs, for example, aminoglycosides, furosemide, and neurodegenerative disorders. Now, in sensorineural hearing loss, the hearing loss may be profound, more than 95 decibel hearing loss. Natural history does not improve and may progress. Management, amplification, or cochlear implant if necessary. Now, in conductive hearing loss, the cause the otitis media effusion, glue ear eustachian tube dysfunction, as in Down syndrome, cleft palate, Parry-Robin sequence, and midfacial hypoplasia. Wax only really a cause of hearing loss. Now, hearing loss would be maximum of 60 decibel hearing loss, and natural history would be intermittent or resolves. Management would be conservative, amplification, or surgery. Now, a little bit of summary in the box. Hearing loss, sensory neural hearing loss, is usually present at birth and is irreversible. Early amplification with hearing aids or cochlear implants is needed for severe hearing impairment. For optimal speech and language development, assistance is required from pediatric teachers for children with moderate severe hearing impairments. Conductive hearing loss is usually due to middle ear disease, often otitis media, where effusion is usually mild or moderate and transient. Consider insertion of tympanostomy tubes, grommets with or without the removal of adenoids if it does not resolve. Now, abnormalities of vision and the ocular system. Normal visual development tests of visions are described in our previous video, which is of chapter 3 of the same book. Visual impairment may present in an infant or young child with obvious ocular malformation, for example, anophthalmia, absent red reflex or white reflex leukocoria, which may be due to opacification of intraocular strictures, corneal abnormalities, intraocular tumor, retinoblastoma. Not smiling responsibly by 6-week post-term. Concerns not smiling responsibly by 6 weeks post-term. Concerns about poor visual responses, including poor eye contact, roving eye movements, nystagmus, and squint. Any infant presenting with an ocular abnormality needs prompt referral to an ophthalmologist, as some underlying conditions are sight-threatening and retinoblastoma is life-threatening. Nystagmus is a repetitive illuminatory rhythmic eye movements. It is usually horizontal but can be vertical. It may be found in social with structural eye problems, sensory defect, nystagmus, but can also be a consequence of problem at the cortical level. Nystagmus, which is a manifestation of an eye problem, may improve over time if no structural eye or brain problem is found. A diagnosis of idiopathic nystagmus is made. Squint, strabismus. In this common condition, there is misalignment of the visual axis. Squint should be assessed in order for the underlying cause to be identified and treated where possible. There may be a family history. Transient misalignment is common up to 3 months of age. Marked epicanthic folds may give an appearance of a squint. Any infant with a squint should have red reflexes checked. Squints persisting beyond 3 months of age should be referred for a specialist ophthalmological opinion. The most common underlying cause is refractive error, but cataracts, retinoblastoma, and other intraocular causes must be excluded. Squints are commonly divided into concomitant and paralytic. Concomitant, non-paralytic, common, usually due to refractive error in one or both eyes. Correction of the refractive error with glasses often corrects the squint. Squinting eye most often turns inward conversion, but there are outward diversion or really vertical deviations. Paralytic rare, varies with gaze direction due to paralysis of the motor nerves. This can be sinister because of the possibility of underlying space occupying lesions such as brain tumor. Corneal light reflex test. Non-specialists can use this test to detect squints as shown in the figure 4.8, which shows corneal right reflection test to detect a swing. The reflection is in the different position in the two eyes because of small convergent squint of the right eye. Now, a pen torch is held at a distance to produce reflection on both corneas simultaneously. If the light reflection does not appear in the same position in the two pupils, a squint is present. However, a minor squint may be difficult to detect. Cover test. The child is encouraged to look at the toy light. If the fixing eye is covered, the squinting eye will move to the taker fixation as shown in the figure. The test should be performed with near 33 centimeter and distant at least 6 meter objects such as certain squint are present only at one distance. These tests are difficult to perform. Reliable results are best obtained by an orthoptist or ophthalmologist. Now, refractive errors, hypermetropia, long sight. This is the most common refractive error in young children. Mild hypermetropia is common in early childhood and is overcome through the process of accommodation, changing the shape of the lens in the eye. Hypermetropia can be corrected with convex plus lenses. These make the eye look bigger. Mild hypermetropia may not need spectacle correction. Next is myopia. This is relatively uncommon in young children, presenting usually in the adolescence. However, in children born preterm, it is the most common refractive error and may present at a younger age. Myopia can be corrected with concave minus lenses. These make the eye look smaller. Astigmatism, abnormal corneal curvature. Minor degree of astigmatism are common and may not cause problems or require correction. Neonatal astigmatism can result in amblyopia. Amblyopia, this is a potentially permanent reduction of visual acuity in an eye that has not received a clear image. It affects 2 to 3% of children. It is usually unilateral but can be bilateral. The most common causes of amblyopia are squint, refractive errors, and obstruction to the visual pathway, for example, cataract. Amblyopia may occur in squint when the brain is unable to combine the markedly differing images from each eye. The vision from the squinting eye is switched off to avoid double vision. Treatment entails tackling the underlying condition together with patching of the good eye for specific periods of the day to force the lazy eye to work and therefore develop better vision. Early development is essential as after 7 years of age, improvement is unlikely. Considerable encouragement and support should to be given often to both the child and parents, as young children usually dislike having their better eye patched. Amblyopia may be asymptomatic and is the main target condition for preschool vision screening in the UK. Severe visual impairment, this affects 1 in 1,000 live births in the UK but is higher in developing countries. The main causes are listed in the box shown. The causes of visual impairment: genetic, which is cataract, albinism, retinal dystrophy, retinoblastoma, antenatal and perinatal, which are congenital infections, retinopathy of prematurity, hypoxic ischemic encephalopathy, cerebral abnormality or damage, optic nerve hyperplasia, postnatal trauma infection, and juvenile idiopathic arthritis. Recent epidemiological studies suggest that in the UK, up to 50% children have cerebral pathology as the underlying cause. About 1/3 of cases are hereditary, affecting eye structures. In developing countries, acquired causes such as infection are more prevalent. Investigations may include an electroretinogram or visual evoked potentials. When visual impairment is of cortical origin resulting from cerebral damage, examination of the eye, including the pupillary responses, may be normal. Although few causes of severe visual impairments can be cured, early detection allows certain elements to be treated, and timely advice can be given on supporting developmental progress. In the UK, this advice is usually provided by pediatric teachers for children with visual impairments who work with families from the time of diagnosis, irrespective of the child's age. Input from a pediatrician and other members of the child developmental team are also required. Partially sighted children may benefit from provision of low vision aids, high-powered magnifiers, and small telescopic devices and computers. Although many severely visually impaired children have a visual disability alone, at least half have additional neurodevelopmental problems. Now the summary regarding vision, visual impairment and ocular abnormalities include refractory errors and are more common in children with neurodevelopmental problems. An absent retroflex or white reflex or a squint persisting after 3 months of age refer to an ophthalmological opinion. Abnormal eye movements in an infant, absence of responsive smiling, or parental concern about vision at any age consider visual impairment and refer to an ophthalmological opinion. Testing for squints, corneal light reflex, reflection test for the non-specialist, cover test for the specialist, and myopia may be asymptomatic. Treatment often include patching of the good eye for short periods each day. Now, multidisciplinary child developmental services. Although children with a wide range of conditions have additional needs, the term special needs is usually used for children with developmental problems and disabilities. In order to optimize the child's assessment and care on an ongoing basis, child development services in the UK are based on geographical areas and are secondary care services. A child development service is multidisciplinary with predominantly health professionals, pediatrician, physiotherapists, occupational therapists, speech and language therapists, clinical psychologists, specialist health visitor, and dietitian in the team, but often also include a social worker, and is as shown in the figure, which shows now showing the common medical problems. Starting from the top: hearing, conductive or sensory neural, vision, squint impaired, visual acuity, visual field deficits, orthopedic, hip subluxation, dislocation, fixed joint contractures, dynamic muscle contractures, painful muscle spasms, spinal deformity, osteoporosis, fractures. Specialist health visitors help coordinate multidisciplinary and multi-agency cares. Advice on development of play or local authority schemes, for example pottage. Dietitian advice on feeding and nutrition. Social worker, social services advice on benefits. Disability, mobility, housing, respite care. Voluntary support agencies, day nursery placements, advocate for child and family, register of children with special needs, psychologist, clinical and educational, cognitive testing, behavioral management, educational advice, GIT, gastroesophageal reflux or motoring coordination, aspiration of food or saliva, constipation, urogenital, urinary tract infection, delay in establishing continence, unstable bladder with psychoureteric reflux, neuropathic bowel and bladder, respiratory infections, aspiration and pneumonia, chronic lung disease, sleep apnea, neurological epilepsy, microcephaly and hydrocephalus, cerebral palsy, nutrition, poor weight gain and faltering growth, behavior, organic or reactive sibling behavior, parental distress. The yellow blocks show child developmental services and pediatrician, assessment, investigation and diagnosis, continuing medical management, coordination of input from therapists and other agency, health, social services and education, speech and language therapist, feeding, language development, speech development, augmentation and alternative communication, ACC, aids, for example Makaton sign language, bliss symbol boards, voice synthesizers, occupational therapist, eye-hand coordination, activities of daily living, ADL, feeding, washing, toileting, dressing, writing, seating, housing adaptations, physiotherapist, balance and mobility, postural maintenance, prevention of joint contractures, spinal deformity, mobility aids and orthosis. The Second one is a multi-agency and may include health, social services, education, volunteers, voluntary agency, parent support groups as shown in the figure, aims to provide a coordinated services with good interagency liaison to meet the functional needs of the child and optimizes his or her care, may provide multidisciplinary support and monitor children up to school leaving age 16 to 19 years, maintains a register of children with disabilities and special needs, has emphasis on children's need within the community, home, nursery, school, regardless of its location. Child development services in the UK now usually use the Common Assessment Framework to allow multidisciplinary sharing of information. The emphasis is on diagnosis, assessment of functional skills, mobility, hand function, vision, hearing, and communication, behavior, social self-care skills and learning, provision of therapy, regular review, a coordinated approach to care, multidisciplinary, multi-agency. Many children with special needs have medical problems which require investigation, treatment, and review. Good interprofessional communication is vital for well-coordinated care. This is assisted by all professionals keeping entries in the child's personal child health record up to date. In addition to locally organized child developmental services, specialist neurodisability services are required for rehabilitation following acquired brain injury, surgery for cerebral palsy, scoliosis, gait analysis, spasticity management, including botulinum toxin injection to muscles, epilepsy, unresponsive to two or more anticonvulsants, or where there is severe cognitive and behavioral regression related to epilepsy, complex communication disorders, diagnosis and therapeutic intervention, mixed complex learning problems, often with neuropsychiatric comorbid symptoms, provision of communication aids, as shown in the figure, sensory impairments, for example, cochlear implants. An example of a touchscreen as shown in the figure, communication, speaking communication, and to assist children who may have speaking and movement disabilities. Children with severe visual and hearing impairments, specialized seating and wheelchairs, and orthosis as shown in these figures. The first one is a boy with spastic cerebral palsy is able to walk with the help of frame, and B is motorized wheelchair enables this young person with cerebral palsy to be mobile. Management of movement disorders, for example, continuous infusion of intrathecal baclofen, selective dorsal rhizotomy, and deep brain stimulation to basal ganglia. Needs are likely to change over time, with key stages being at transition to school and adult services. A care plan should be developed at every stage. It may include education and social care as well as health. Care plans should be shared with the child and family and then regularly reviewed. Involvement with specialist services may be of variable frequency throughout childhood. Collaboration across services is vital in promoting a service tailored around the child and family. Summary. Excuse me. Children with developmental problems and disability are looked after by local multidisciplinary child developmental services, often have complex medical needs, need regular review as needs change with time, as will the child's ability to participate in it. Require coordination of care between the family and the many professionals involved, as well as close liaison with education and social services. Education. Children with special educational needs should receive education input according to their requirements and including integration into mainstream schooling wherever and whenever possible. However, there are special needs schools for children with no significant learning and or physical disability. There are also specialist education placement for children with certain conditions such as severe visual or hearing impairment or autism spectrum disorders. These specialist educational settings have access to a higher level of therapies, physiotherapy, occupational therapy, speech and language therapy, and specialist teaching than are available through a mainstream education placement. Assessment and support suggest Assessment support for behavioral and learning needs may come from an educational or clinical psychologist. Transition of care to adult services in the UK, adult disability services are in general still poorly developed by comparison with those provided for children. Young adults with severe learning and physical disabilities are supported by adult learning disability teams, but there is only limited national provision for those with mild or moderate learning disabilities or with a predominantly physical disability. Major problems for young adults with disabilities include social issues around care, housing, mobility, finance, leisure, employment, and genetic and sexual counseling. Health information must be properly transferred from child to adult health services if reinvestigation of already well clarified condition is to be avoided. The rights of disabled children, irrespective of their disability, the aspiration and rights of children as affirmed by the United Nations Convention on the Rights of the Child need to be respected. Technological advances to improve mobility, communication, and emotional expression are helping enable people with disability to better achieve their full potential rather than being held back by the disability. However, this requires skilled assistance and adequate resources. Prominent public figures who function effectively despite disabilities help to make the public appreciate what can be achieved and serve as an inspiration to those with disabilities. The World Health Organization stresses the important outcomes of activity and participation. Any health intervention with people with disability, either on an individual level or in society as a whole, should aim to also improve these outcomes. This is the end of this chapter. Thank you very much.